All right, welcome. If you're getting ready for your MRCP Part 1, you know that endocrinology can be tricky. So today, we're going to tackle a topic that comes up all the time, Addison's disease. We're going to cover everything you need, from spotting those classic signs to handling an emergency, all packed with the high-yield facts you need to smash it on exam day.
Okay, let's jump straight in with a classic exam vignette. You see this trio of symptoms in a question: deep fatigue, a really specific craving for salt, and that telltale darkening of the skin. Right away, your brain should be screaming one particular diagnosis. Nailing this kind of pattern recognition is exactly how you score points.
And there you have it, Addison's disease. So what is it really? At its heart, it's primary hypoadrenalism. This means the adrenal glands themselves are failing, and the number one cause? The body's own immune system is attacking them. The bottom line is you lose two absolutely critical hormones, cortisol and aldosterone.
So here's our game plan. We'll start with the classic signs you've got to spot. Then we'll walk through exactly how to diagnose it. After that, we'll talk treatment and, crucially, how to handle that life-or-death situation and Addisonian crisis. Right, Part 1, recognizing the full clinical picture. This is your first step to absolutely owning any question on this topic. So let's look at the clues the examiners love to throw at you.
So it all starts with this collection of symptoms. You've got the vague stuff like tiredness and weakness, sure, but it's the specific clues that really matter. Be on the lookout for weight loss, that classic salt craving, which is a huge clue for aldosterone deficiency, and low blood pressure. Oh, and remember to look for other autoimmune signs like vitiligo.
Now this brings us to the single most specific sign, the one thing that helps you tell Addison's apart from other causes of adrenal failure. Why on earth do these patients get that bronzed, tanned look, especially in the creases of their palms? Understanding the why here is a game changer for your exam.
And the answer is all about something called the POMC pathway. Just think of propiomyelanocortin, or POMC, as this big parent molecule. When the brain is desperately trying to get more cortisol, it churns out tons of POMC. And when POMC gets chopped up, it makes two things: ACTH to kick the adrenals, and MSH, melanocyte-stimulating hormone.
This slide really breaks it down. In primary Addison's, the adrenal glands are shot, so the pituitary gland goes into overdrive, pumping out massive amounts of ACTH and, as a side effect, MSH. That's what causes the hyperpigmentation. But in secondary adrenal insufficiency, the pituitary gland itself is the problem. ACTH and MSH are low, so you get no skin darkening. This distinction is a classic exam question, so make sure you've got it down.
Okay, so you've seen the signs and you're thinking Addison's. How do you actually prove it? Let's dive into the diagnostic pathway and the key numbers you've got to know. You know, the algorithm here is actually really neat and logical. You start with a simple screening test, a 9 a.m. cortisol level. If that looks iffy, you move to the gold standard test, the ACTH stimulation test, which you'll know as the short synactin test. And finally, to prove it's autoimmune, you check for those adrenal autoantibodies. Simple as that. Now screenshot this, write it down, do whatever you have to do to memorize these numbers. A 9 a.m. cortisol over 500? Addison's is basically off the table. A level under 100? Your alarm bell should be ringing. In that gray zone, between 100 and 500, that's your trigger to order the synactin test to get a definitive answer. Let's talk electrolytes. You know, because there's no aldosterone, you can get low sodium and high potassium, hyponatremia and hyperkalemia. But, and this is a huge but, these classic changes are only there in about a third of patients when they're diagnosed. So don't let a question with normal electrolytes throw you off the scent.
So you've confirmed the diagnosis. Now what? We move on to management. And this is for life, which means that educating your patient is every bit as important as writing the prescription.
The treatment is pretty straightforward. You replace what's missing. We use hydrocortisone to replace the cortisol, usually split into a few doses to copy the body's natural rhythm. And for the missing aldosterone, we use fludrocortisone. That's the one that's key for managing salt and water balance.
If you only remember one thing about patient education, make it this: the sick day rules. These are absolutely non-negotiable. You see, when a healthy person gets sick, their body floods with cortisol to cope with the stress. Addison's patients can't do that, so they have to manually increase their dose. Forgetting to do this isn't just a mistake, it can be fatal.
So the safety net for these patients has a few key parts. They have to understand that they can never miss their meds. They need to wear a medical alert bracelet or carry a steroid card. And this is a big one,
They need an emergency kit at home with injectable hydrocortisone for when they're vomiting and can't keep their tablets down.
And that leads us perfectly into the most dangerous part of Addison's disease, the Addisonian crisis. This is a full-blown medical emergency, and you need to know exactly what to do without hesitation.
A crisis doesn't just happen out of nowhere. Something triggers it. The most common trigger is someone suddenly stopping their steroids. But it can also be a bad infection, a major surgery, or just not following those sick day rules during a simple stomach bug.
The protocol here is crystal clear, and you have to act fast. Do not wait for labs. Step 1, always, is hydrocortisone 100 milligrams IV or IM, stat. Then you hit them with fluids, a liter of normal saline, fast. Check for low blood sugar and correct it. Continue the steroids with an infusion, and all the while, you're hunting for and treating whatever pushed them into the crisis in the first place. And here is a fantastic, high-yield pearl that trips a lot of people up in exams. In an acute crisis, you do not need to give oral fludrocortisone. Why? Because the massive doses of IV hydrocortisone you're already giving have enough mineralocorticoid activity to take care of the salt and water balance for now.
So, let's boil this all down to the absolute essentials. For your exam, here's the deal. Recognize the classic picture, that skin darkening and salt craving. Diagnose it with a 9 a.m. cortisol followed by a synacthin test, and treat it with hydrocortisone and a rock-solid understanding of those sick day rules.
Okay, let's finish with one last question to really lock this in. Your patient is a known Addisonian. They come in with a fever, and they're vomiting. They can't keep their pills down. What is your immediate, life-saving next step? If the first thing that comes to your mind is give 100 milligrams of hydrocortisone IV or IM right now, then you've absolutely got this.